Hello everyone, I am Dr. Keshav Pawar from Department of Oral and Maxillofacial Surgery from Sri Balaji Dental College and Hospital. Today I am going to talk about oral cancer, its basic principles and prospects. Uh, Cancer is basically defined as an uncoordinated and uncontrolled growth of the tissue resulting from multiplication of its cells and the condition persists even after the stimulus or the initiating factor is. The types of intraoral malignancies are the tumors originating from the surface epithelium like squamous cell carcinoma and melanoma. Squamous cell carcinoma is the most common type of cancer, which constitutes of about 90 to 95% of all the cancers. Tumors originating from the glandular tissues like the salivary glands, metastatic cancer from breast, prostate, and lungs, which are adenocarcinoma, adenocystic carcinoma, mucoepidermoid carcinoma. The tumors which are originating from the mesenchymal tissues are sarcoma and lymphoma. Sarcoma includes osteosarcoma, chondrosarcoma, fibrosarcoma, and Ewing's. So the some of the irritants which can be tobacco, alcohol, and viruses. Tobacco has been showed that people smoking more than 40 or more cigarettes a day uh, are generally 5 to 10 times at more risk than the non-smokers. Alcohol, it possibly acts as an irritant or solvent which facilitates penetration of mucosa by other carcinogens like tobacco. It may also suppress efficiency of DNA repair after exposure to carcinogens. Viruses, HPV, herpes simplex virus, HIV virus, Epstein-Barr virus, these all can promote act as an irritant and promote cancer. Poor dental hygiene and constant chronic trauma to mucosa due to dental cause or sharp tooth, ill-fitting dentures, sharp crown and bridges, etc. can lead to cancerous changes in the tissues. Radiations, hereditary syndromes like basal cell nevi syndrome, uh, uh, xeroderma pigmentosa, uh, and also pre-malignant lesions like leukoplakia, lichen planus, tertiary syphilis, chronic candidiasis, Plummer-Wilson syndrome, and also can cause an reaction which leads to cancer. And malnutrition like mineral deficiency and vitamin deficiency can also lead to decrease in the immunity and in turn lead into cancer. The spread of squamous cell carcinomas of the oral cavity is mainly through local infiltration, and which leads to invasion of local soft tissues, then invasion of the perineural spaces, and eventually bone. Lymphatic spread, which is mostly through the lymph nodes, uh, it is a quite good method. It is a quite method for metastasis, and metastasis can also be through blood, which can cause a systemic spread of the history, which includes history of general health, any pain in the chest, limited exercise tolerance, exertion after exercise, shortness of breath, past personal history, past medical history, or any surgeries which have been done in the past, and also systemic conditions like hypertension, diabetes, anemia should all be considered. The history of the lesion, mass or ulcer, the onset of the occurrence, duration, pain, and the type of swelling which has been there should be carefully examined. Clinical examinations, which will be extraorally and intraorally. In extraoral examination, the exam rigorous examination of head, face, and neck for any asymmetry or changes in the color of the skin should be done. Any s- uh, swellings should also be examined properly. Examination of the regional lymph nodes should be done bilaterally. Intraoral examination of the size, shape, and tenderness of the ulcer. Also checking the borders of the ulcer, which becomes a identifying factor in some of the radiographical examination by OPG, CT, and CECT scans, which is better to assess the bony involvement, and MRI scans, which are better for assessing the soft tissue extents and involvement. Sometimes we also need chest X-ray to exclude metastasis to the lung. Laboratory investigations like blood, a complete blood picture, blood sugar, blood urea, and enzymes like liver function test, renal function test, and serum electrolytes should be done. Biopsy should be taken, which gives a clear picture of the disease which is present, and there are several types of biopsies. It is excision biopsy, incisional biopsy, aspirational biopsy, punch biopsy. Excisional biopsy is usually used when the lesion is small and the complete lesion is the part of a lesion is excised, and it's taken for further histopathological examination. uh, Punch biopsy. Punch biopsy, it is of limited value in the oral cavity. It is useful generally when the tissue is then when the sample is small, and it has to be taken from inaccessible areas like lateral or pharyngeal walls, or or in maxillary sinus. Incisional biopsy is mainly indicated in large lesions, or when complete excision is not possible. Clinical features of oral cancers. Classically, they present either as a soon non-healing ulcer with varying degrees of pain and occasional episodes of bleeding from the lesion, usually having an irregular edge and induration of the underlying soft tissues. Exophytic growth of duration may be several weeks to a few months before patient seeks treatment. Exophytic growth may be also present. It may present like a cauliflower, like having irregular growths, or it may be flat, or it may have some other shape. More advanced lesions can present with pain, bleeding, or fixity to the surrounding structures. Cancers that involve the infratemporal fossa present with recent onset of trismus. This must be distinguished from the long-standing trismus, which is a sign of oral submucous fibrosis. Lesions can also present with metastatic disease to the regional draining cervical nodes. It is important to remember that occasionally lesions in alveolus and around the non-healing tooth extraction socket manifest with unexplained loosening of the involving teeth. TNM staging is very famous, and it's considered as the gold standard to know the stage of the cancer, or where the disease spread is at. Clinical staging system designed to express the severity or extent of the disease. Like, it has three staging processes. T staging, which tells about the tumor size. If N staging, which accesses the regional lymph node involvement, and M stage, which tells about the metastasis. In T stage, if it is T0, there is no evidence of primary lesion. Carcinoma in situ is TS, which indicates the presence of the lesion in the person's oral cavity. T1 lesion T1 indicates 2 centimeters or less in diameter. T2 lesions are more than 2 centimeters, but they are less than 4 centimeters in diameter. T3 lesions, which are the largest, which can be more than 4 centimeters to any extent. And T4, which invades the adjacent structures like muscle, bone, and maxillary sinus. End staging refers to the lymph nodal involvement, and N0 represents no regional lymph nodes are involved. N1 it tells that the lesion is metastatized to a single ipsilateral lymph node. Less than 3 centimeters is in the greatest dimension. N2 metastasis is a single ipsilateral lymph node, which is 3 to 6 centimeters in diameter, or it can be multiple ipsilateral lymph nodes, which are less than 6 centimeters in diameter, or bilateral or contralateral lymph nodes. N3 metastasis includes the lymph nodes which are increased in size more than 6 centimeters. So to recollect, N1, which is less than 3 centimeters of size of the lymph node, N2 is between 3 to 6 centimeters, and N3 is more than 6 centimeters. M stage, it denotes distant metastasis, and M1 represents the distant metastasis is present, which clearly tells that the cancer has spread. The histological grading, it represents the grading of degree of it represents the degree of resemblance of tumor cells to the original cells. It determines the aggressiveness of tumor, how well it is differentiated, and how is the mitotic activity, and how undifferentiated it is from its original cells. And it does not with the lesion which doesn't produce keratin is considered to be as the most aggressive type of tumor. Here you can see the types of neck dissection involved in level depending on number of node it spreads. And you can see in radical neck dissection, the node level dissected is 1 to 5. In type 1 modified radical neck dissection, it is 1 to 5. In type 2, it is 1 to 5. And type 3 also, it is 1 to 5. Supramyohyoid neck dissection is indicated in the lesions which is spread from 1 to 3 level lymph nodes, and lateral neck dissection from 2 to 4 level of lymph nodes, and anterolateral neck dissection is indicated in 1 to 4 level of lymph nodes. Posterolateral neck dissection, which involves level 2 to level 5 spread of lymph nodes, and the structures preserved, which you can see. These are the 6 level of lymph nodes present in the neck region, and which can be seen more clearly in this. There are preauricular lymph nodes, posterior auricular lymph nodes, tonsillar lymph nodes, occipital lymph nodes, superficial cervical lymph nodes, posterior cervical lymph nodes, supraclavicular lymph nodes, submental lymph nodes, submandibular and deep cervical chain lymph nodes. And the picture in the below, you can see the swelling of lymph nodes, which is clearly visible. It can be between N2 and N3, which is 3 to 6 or more than 6 centimeters. Overall, in human body, there are 800 lymph nodes, of which 300 of it are present in head and neck region. Histological grading of the cancer, it is done through G1, G2, G3, and G4, which means G1 is well differentiated, G2 is moderately differentiated, G3 is poorly differentiated, and G4 is undifferentiated. Management can be done by surgery, radiotherapy, chemotherapy, and additional treatment modalities, which can be immunotherapy, photodynamic therapy. Surgery is the most preferred treatment of choice, and it is possible to operate during the first and second stages. And it is more favorable to operate in the first two stages, and in the third and fourth stages, it becomes difficult as it is already spread to a more number of spread to farther lymph nodes, and surgery becomes an important difficult task. So in third and fourth stages, it is mainly done by radio or chemotherapy. Advantages of surgery are it is fast, and we can also repeated procedures can be possible. It is effective. The Because when chemotherapy and radiotherapy, it costs more when compared to performing a surgery. And disadvantages of the surgery are aesthetic alteration, inability to precisely eliminate foci of microscopic lesion, relatively high incidence of complications like infections, orocutaneous fistulas, and etc. But nowadays, as the aesthetics are well versed, and it becomes a challenge, and it is taken up to it. These are another pictorial representation of the TNM data. Advantages of radiotherapy: it is minimal aesthetic and function and causes minimal functional alteration. Ability to sterilize microscopical tumor cells, because after the therapy we can observe the changes, and if any tumor cells are left behind, it can be killed with another episode of radiotherapy. And disadvantages of radiotherapy are ineffective to ablate large tumor volume, acute and chronic morbidity, prolonged treatment, not suitable for treatment if the lesion involves or is close to the bone. Selection of the treatment modality depends on the stage of cancer. Early stage can be treated with single treatment modality, which is surgery or radiotherapy. Advanced cancers, which requires combined modality treatment like surgery and radiotherapy, which also follow is also followed by chemotherapy, treated palliatively. Criteria for considering considering tumor inoperability depends on recent onset of trismus, or involvement of skull, or if there is any distant metastasis. Management of neck lymph nodes can be done by marking the site and location of the primary lesion, tongue and floor of the mouth, and seeing which is more at risk of spreading than a hard palate lesion. the size of the primary site, the T stages, and irrespective, and sometimes irrespective to the site, histomorphologic features, poorly differentiated carcinoma have increased metastasis than the well differentiated carcinoma. Surgical treatment, which I have already explained previously, involves a radical neck dissection, modified neck dissection, and selective neck dissection, depending upon the spread of lymph nodes and also the lymph nodes which are suspected to be spreaded by the lesion. Principles of reconstruction of the mucosal defects can be dealt by following by following these modalities, like leaving the raw areas, allowing it to heal by granulation tissue or by secondary intentions, primary closure of the uh, operated site, covering it with skin grafts, and finally covering it with flap. Reconstruction of bony defects can be done by external materials also, like implants, like alloplasts, like plates, allografts, or autografts. Survival and prognosis depends on the stage of the disease. Stages 1 and 2 have better prognosis, and it has at least 5-year survival rate, with 31 to 100% of people surviving at least 5 years or more. Whereas in advanced stages 3 and 3 and 4, they have poor prognosis, and the 5-year survival only is in 7 to 41% of population. Being a dental practitioner, we should focus more on early detection of the cancer, which plays a major role in preventing or uh, preventing the spread of the lesion. It is important to examine the entire oral cavity while performing routine dental care to pick up suspicious lesions. Dental care prior to commencing radiation is very important and involves oral prophylaxis, fluoride application, extract hopeless, and restore caries teeth. Patient education post radiotherapy is very important, that the good oral health should be maintained. Maxillofacial processes fabrication, both intra and extraoral, can be fabricated to replace teeth, nose, ear, and eye